afternoon, everyone. So today we are going to start the case-based learning session presented from the Department of Cardiopulmonary Physiotherapy by Mr. Ravinder. He is a second year MPT cardiopulmonary student. He is going to present a case on post-operative adhesiolysis with double barrel ileostomy for adenocarcinoma of sigmoid colon case. So we will continue with the session.
Thank you, ma'am. Good afternoon to everyone. My name is Ravinder from cardiorespiratory physiotherapy, second year student. Okay, my topic is a post-operative adhesiolysis of with double barrel ileostomy for adenocarcinoma of sigmoid colon. Case scenario: name Mr. Leena Das, age 36, female. Date of assessment is 5 December 2025. Hospital number 058831 and referral department is general surgery. A case came with a post-operative status following a re-exploratory of laparotomy with adhesiolysis and double loop ileostomy, repositioning of anastomotic leak following adenocarcinoma of sigmoid colon. A chief complaint: abdominal pain, especially during passing urine, discomfort due to leakage of stroma bag, decreased endurance and generalized weakness, fear of movement due to repeated abdominal surgery. History of present illness. A patient is a known case of adenocarcinoma of sigmoid colon for which a transverse loop colostomy followed by an anterior resection and anastomosis was performed on September 2025. Subsequently, the patient underwent a stoma closure in October 2025 due to development of an anastomotic leak. An exploratory laparotomy was done in November 2025. This was followed by a re-exploration laparotomy with adhesiolysis on 17th November 2025. Most recent, the patient underwent a double loop ileostomy repositioning on December 3rd. Is currently on the post-operative day 2. The patient now presented with a pain during urinating, reduced mobility, and compromised pulmonary mechanism and functional limitation. Past medical history: not known case of type 2 diabetes mellitus, hypertension, thyroid disorder, and post-TB. Case scenario: pain assessment, site, lower abdomen, and surgical incision. Nature: deep and pulling pain. Intensity: 6/10 on numerical pain rating scale. Aggravating factor: maturation, coughing, rolling in bed, and sit to stand. Relieving factor: rest, abdominal splinting, and analgesia. On observation: patient conscious and oriented, guarded position due to abdominal pain, presence of double loop ileostomy with stoma bag, noted leakage, surgical incision was with dressing in, slow and caution movements. Vitals: heart rate of 88 beats per minute, BP 130/84 mmHg, respiratory rate 23 cycles per minute, SpO2 97% at room temperature. On palpation, body temperature is normal, skin temperature normal to mild increase around the incision. Tenderness present at a surgical site, muscle tone increased, protective guarding. Stoma site, mild tenderness, no hardening or abnormal warmth. Respiratory system assessment: breathing pattern shallow and thoracic dominant. Accessory muscle usage mild. SCM, stenocardial mastoid activation is seen. Lung auscultation, bilateral air entry present. Breath sound vesicular in nature. Breath sound intensity reduced to basal lung region of bilateral. No added sounds. Diaphragm assessment: diaphragmatic excursion is limited in bilateral dooms. Caudal movement during inspiration is reduced. Symmetrically reduction on the both side of the lung. Thoracic cage expansion level using a tape, the axillary level of 2.5 centimeter, nipple level 2.3 centimeter, xiphoid sternal level 1.9 centimeter. A cage movement assessment: upper limb, first 5 ribs near normal, lower 6 to 10 ribs restricted, and pump handle and bucket handle movements are reduced. Effect of assessment: inspiratory effect of 900 cc per minute using an incentive spirometry. cough effect is weak and ineffective. Pathophysiology of this condition is patient came with a sigmoid colon adeno cancer, a surgical resection, and adenomyosis and ileostomy. Abdominal incision, pain, it's reduced diaphragmatic excursion, leads to low lung volume and ineffective cough and risk of aterostatus. A problem identification according to the ICF model, impairments, a reduced thoracic expansion, decreased diaphragmatic excursion, weak abdominal musculature, pain at surgical site, activity limitations, difficulty in bed mobility, pain during cough and transverse activity, reduced walking endurance, participation restrictions, reduced independence in daily activities, limited mobility, confidence. Clinical reasoning pathway. Assessment, with assessment, reduced chest expansion, weak core muscle and pain, problem risk of pulmonary compilation and reduced functional capacity. Goal to improve the ventilation, mobility and independent activity. Intervention, breathing exercise, mobility training, core activation. Expected outcomes, improved chest expansion and functional independence. Functional assessment, FIM score 4/7, a minimal assistant, subject is able to do the activity of 75%. ICU mobility scale 8/10, walking with assistance of 1 person. Tuck test, achieved 3 meters in 1.32 minutes with assistance. Treatment goal, a short-term goal, a reduced pain during breath and movements, improve lung function and cough effectives, achieve independent bed mobility, educate patient on safe movement with stoma bag. Long-term goal, restore functional independence, improve endurance and ambulation, prevent post-operative pulmonary complication, prepare patient for discharge and further rehabilitations, improve patient's quality of life. Intervention phase, the phases are divided into 3 according to the phase 1, first 2 days, a patient is doing the diaphragmatic breathing exercise, segmental breathing for especially for lower lips, incentive spirometry, sprinted cough and education, active ROM exercise in bed. Phase 2, from day 2 to day 7, thoracic expansion exercise, diaphragm facilitation training, gentle core activation, sit to stand training, yearly assisted ambulation, where the patient from 4th day, the patient is started to ambulate with minimum support. Phase 3, from 2 to 3 weeks, progression walking without assistance to achieve the goal of 7 minutes, functional task training and postural corrections. 2-minute walk test, assessed on 12 December of 2025. Vitals were checked, pre-test and mid-test and post-test. Recovery of 2 minutes and recovery of 5 minutes. Heart rate at pre-test is 90 and recovery after 5 minutes is 92. Breath rate is 18. After recovery, patient is 20. Rate of perceived excursion is at early stage 1. After recovery of 5 minutes is 1. Patient able to recover soon. BP, pre-test BP value is 125/82 mmHg. After 5 minutes recovery, 128/82. Patient able to achieve their normal values after recovery of 5 minutes value. Distance covered during the 2 minutes walk test is 1.15 meters. Outcome measure have included of day of assessment and phase 3 assessment. NPRS scale, pain scale, day of assessment is 6/10. After intervention and phase 3 assessment 4/10 is reduced. Expansion of chest expansion at sufficient level. The day of assessment is 1.9 centimeter. At phase 3 assessment 2.5 centimeter. Respiratory rate during day of assessment is 23 minutes. After the phase 3 assessment 19 per minute. Ambulation distance a day of assessment is 15 meter. Day 3 assessment 45 meters. FIM score. Day of assessment is 4/7 minimal assessment. Subject is 75%. And at a phase 3 assessment 5/7 supervision, subject can do 100% of their work activity. ICU mobility score, walking with assistance of one person on day of assessment, walking independently without a gait aid on phase 3 assessment. Evidence integration, a yearly mobilization reduces the post-operative after abdominal surgery. Breathing exercise improvement lung volume and post-laparotomy. Core activation improves the trunk stability on post-trauma surgery. Reflection and critical thinking, pain management is key to respiratory recovery. Early mobilization prevent pulmonary complications. Multi-system involvement requires holistic approach. Summary of the case is the patient is on day 2 post-operative following a double loop ileostomy repositioning with a complex surgical history involving multiple laparotomies and additional patient present with pain limited breathing, reduced mobility, functional independence, and stoma related concern. A yearly physiotherapy intervention is essential to prevent the pulmonary complications, enhance recovery, and promote functional independence while ensuring a surgical site and stoma safety. Reference. Thank you.
Yeah, good noon, Ravi. It is actually a nice case presentation. So you have the patient had ineffective cough, right?
Yes, ma'am.
On the day of assessment.
Yes, ma'am.
Yes. So what measures did you take to improve the cough effort?
ACBD technique, ma'am. I just follow the ACBD technique and the huffing and coughing technique to improve the cough effect.
Okay. And on diaphragm, to be specific, in the diaphragmatic assessment, you have also told that the diaphragm excursion was limited, right? So what measures were taken to improve the diaphragmatic mobility?
I just focus on diaphragm by diaphragmatic breathing exercise of proprioception and facilitation training.
Okay, good. So this is actually a good case, and you could have taken a great follow-up even from the starting of the surgery, I hope, because she has underwent a lot of resurgeries, right? So for this patient, my suggestion, you could add on something on psychological support to the patient. The patient might have fear of movement due to pain because she had repeated surgeries and she might be in pain that any movement might disrupt already or might worsen her case, and it might lead to some other surgery also. So she will be in such a fear. So reassurance from the side of the therapist as well as a family education has to be provided to the patient.
Okay, ma'am.
The patient and improve her quality of life. So that is my suggestion.
Okay, ma'am.
Good evening, everyone. Am I audible?
Yes, sir.
Yes. Okay. It was a nice presentation. You just try to cover the maximum concept of the case and also the treatment. I just have only one concern. You could have added some MCID, the minimum clinically identifiable difference of those scales. Like you have mentioned about 2 minutes walk test and some scales, right?
Yes, sir.
Are you able to achieve those minimum, the MCID of those scales within given time?
Yes, sir.
Yeah. So this you taken on how many days you took this? On day 1 only you took this, or?
Sir, on POD 4, I took the first test.
Okay.
I just started to yearly ambulate, but I took this test on 12th December, sir.
Okay, you took this test on 12th December, which was POD 4.
7.
POD 7. Okay. Today, what is the POD actually?
Sir, patient is discharged.
Patient got discharged. Okay.
Yes, sir.
That's what you have took this on day 7, right? So
Yes, sir.
at least if you could have had a reassessment of the same on day before of the discharge, we could have seen how improvement was achieved, because this scale shows the effectiveness of the treatment.
Okay, sir.
So that as you assess in the day 1 or some other days, like when you are felt it is comfortable, you are assessing on day 7 or 4, it's fine. But before the day he or she discharged, you could have reassessed it. This would have given a brief understanding how effective your treatment was. Thank you.
Thank you, sir.
Thank you, everyone.
Thank you, ma'am.